stop. Before your next doctor's appointment, I need you to watch this entire video because what I'm about to share with you could genuinely change and possibly save your life. I'm Dr. Emily Walker, and I've spent over 2 decades in medicine. I've sat across from thousands of patients, reviewed the research, and I'll be honest with you the way I'd be honest with my own family. There are 5 medical checkups that, after the age of 70, the science says may do far more harm than good. And number 5, the last one on this list, has a documented history of leading patients down a path of unnecessary treatment, dangerous complications, and in some cases, death. So stay with me, because this is one of those conversations that most doctors simply don't have the time or the courage to have with you in a 15-minute office visit. Now, before we dive in, I want to be absolutely clear about something. I am not telling you to stop seeing your doctor. I am not telling you to ignore your health. What I am telling you is that modern medicine, as brilliant as it is, was built largely around younger, healthier populations. Many of the screening guidelines that doctors follow every day were designed with a 45-year-old in mind, not a 75-year-old. And the medical community is increasingly waking up to the reality that for older adults, more testing does not always mean better outcomes. Sometimes it means exactly the opposite. Let's start with the first one, and this might surprise you: routine annual PSA screening for prostate cancer in men over 70. Now, I know what you're thinking. Cancer screening is important. Catching it early saves lives. And yes, for younger men, that logic holds. But here's what the data actually shows. The U.S. Preventive Services Task Force, one of the most respected medical advisory bodies in the country, currently recommends against routine PSA screening in men over 70. And the reason is deeply important to understand. Prostate cancer, particularly in older men, is almost always extraordinarily slow-growing. Most men over 70 who have prostate cancer will die of something entirely unrelated to it: heart disease, stroke, or simply old age. The cancer never causes them a single problem. But once that PSA test comes back slightly elevated, the cascade begins. More tests, a biopsy. The biopsy carries real risks: infections, bleeding, and yes, in rare but documented cases, sepsis that can be fatal. Then if something is found, the pressure to treat begins. Radiation, surgery, hormone therapy. Each of these treatments carries side effects that can dramatically reduce quality of life: incontinence, impotence, fatigue, depression. And here's the crushing irony. Multiple large studies, including the landmark PROTECT trial published in the New England Journal of Medicine, found that for low-risk prostate cancer, active surveillance, meaning watchful waiting with no treatment, had virtually the same survival outcomes as aggressive treatment. So for men over 70, routine PSA screening too often leads to treating a cancer that would never have harmed them in the first place, while the treatment itself causes significant harm. That is not a trade-off I can recommend with a clear conscience. The second checkup I want to talk about is aggressive cholesterol screening and the treatment decisions that follow for people over 75. Now, I spent years telling patients to get their cholesterol checked and prescribed statins based on those numbers. And for middle-aged adults with heart disease risk factors, statins save lives. The evidence is solid, but something shifts after age 75, and most people are never told about it. Here's a fact that stuns most of my patients. Several large observational studies have found that in adults over 75 who do not already have established heart disease, high LDL cholesterol, the so-called bad cholesterol, is not consistently associated with increased cardiovascular mortality. In fact, some studies have found the opposite. A meta-analysis published in the British Medical Journal, Open, found that high LDL was associated with lower all-cause mortality in older adults over 60. Now, the research is complex and still evolving, but the point is this: the automatic assumption that a high cholesterol number after 75 requires aggressive treatment is not as well supported by evidence as we once believed. Meanwhile, statins carry real risks in elderly patients: muscle breakdown, a condition called rhabdomyolysis, liver enzyme abnormalities, and a significantly increased risk of falls due to muscle weakness. And falls in adults over 70 are not minor events. A hip fracture from a fall is one of the leading causes of death-related complications in this population. So before accepting a new statin prescription based solely on a cholesterol number after 75, I encourage every patient to have a detailed conversation with their doctor about their individual risk profile, their current medications, and whether the benefits truly outweigh the risks at this stage of life. Now we're moving into territory that's going to be even more uncomfortable for some of you, and that's routine mammography screening for women over 70. Please hear me out before you react, because I know how deeply important this topic is. Mammography absolutely saves lives in women in their 40s, 50s, and 60s. There is no debate about that. But the evidence for continuing annual mammograms beyond 70, particularly beyond 75, is far murkier than most people are led to believe. Here is the core issue. As women age, the risk of dying from breast cancer, while still real, begins to be outweighed by competing health risks. Breast cancer, when it develops in older women, also tends to grow more slowly than in younger women, and is often highly treatable even when discovered later. At the same time, mammography in older women carries a particularly high rate of false positives, abnormal readings that turn out to be nothing. And every false positive triggers a chain reaction. Additional imaging, biopsies, anxiety, waiting, and the psychological burden of believing you might have cancer when you don't. Research published in JAMA Internal Medicine found that over a 10-year period of screening, nearly 60% of women will have at least one false positive mammogram. In older women whose tissue density has changed and whose overall health may make aggressive cancer treatment inadvisable anyway, the harms of this cascade can genuinely outweigh the benefits. The American Cancer Society itself now recommends that women have the opportunity to stop screening based on their health status and life expectancy. This is deeply personal, and I am absolutely not saying never get screened. I'm saying, after 70, this decision should be an individualized, thoughtful conversation, not an automatic annual ritual. The fourth checkup I want to address is aggressive blood glucose screening and intensive blood sugar management in type 2 diabetes patients over 70. This is a big one. We have spent decades in medicine driving diabetic patients' blood sugar numbers as low as possible. Tight glycemic control, we call it. And for younger diabetics, that approach genuinely reduces the risk of long-term complications like kidney disease, neuropathy, and eye damage. But for older adults, the picture changes dramatically. The landmark ACCORD trial, one of the most important diabetes trials ever conducted, had to be stopped early because patients in the intensive blood sugar control group were dying at a higher rate than those receiving standard treatment. The reason? Hypoglycemia, low blood sugar episodes. In older adults, hypoglycemia doesn't just make you feel shaky and sweaty. It can trigger dangerous cardiac arrhythmias, cause falls resulting in fractures, lead to loss of consciousness, and in severe cases, cause brain damage or death. Many elderly patients who are chasing an A1C below 7 based on guidelines designed for younger patients are actually putting themselves in serious danger. The American Geriatric Society and multiple endocrinology groups now recommend less aggressive glucose targets for older adults, particularly those over 75, or those with cognitive impairment or multiple chronic conditions. Yet so many of my older patients are still being pushed toward intensive control by well-meaning doctors who haven't updated their protocols. If you or someone you love is over 70 and managing diabetes, please ask your doctor specifically about age-appropriate glucose targets. That conversation could prevent a fall, a cardiac event, or something far worse. And now we've reached number 5. The one I told you at the start of this video could kill you. And I want you to understand. I chose those words deliberately because the data supports them. I'm talking about routine full-body CT scans and comprehensive whole-body imaging screenings that have become increasingly popular and heavily marketed, often directly to consumers, as a way to catch everything early. You've probably seen the advertisements, walk-in imaging centers promising peace of mind. The idea sounds wonderful. Scan your entire body, find any problem lurking before it causes symptoms. But here is the brutal reality that these ads never tell you. The human body, particularly the body of a person over 70, is filled with what radiologists call incidentalomas, findings on imaging that look abnormal but are almost always benign, clinically insignificant, or simply the natural changes that come with aging. A small nodule on your lung, a cyst on your kidney, a shadow near your adrenal gland, a spot on your liver. These findings are extraordinarily common in older adults. Studies suggest that whole-body CT scans reveal incidental findings in well over 80% of older patients. And here is where the danger begins. Each one of those findings triggers follow-up. More scans, more radiation, because CT scans deliver meaningful radiation doses, and cumulative radiation exposure over time does increase cancer risk, something particularly worth noting in older patients. Then come the biopsies. And biopsies in older adults carry compounding risks: bleeding, infection, anesthesia complications. There are documented cases, and I have personally seen this happen, where a patient walked into a screening completely healthy, received a whole-body scan that found an incidentaloma, underwent a biopsy to investigate it, developed a serious complication from that biopsy, and never fully recovered. They were harmed, not helped, by a test they sought out in the name of prevention. A 2019 analysis published in JAMA estimated that the probability of a false positive finding from a single whole-body CT scan is greater than 90%. Greater than 90%. Meaning the overwhelming likelihood is that your abnormal finding is not cancer, not dangerous, not a problem, but the process of investigating it absolutely can be. For adults over 70 who often have reduced physiological reserves and are less able to recover from procedural complications, this risk-to-benefit ratio is genuinely alarming. Unless there is a specific clinical reason, a symptom, a family history that warrants targeted imaging, routine whole-body CT screening is something I would never recommend for a patient over 70, and something I would never do myself. So where does this leave you? It leaves you informed, and informed patients live longer, healthier, better lives. Here is my practical advice. Before any screening test, ask your doctor 3 questions. First, what will we do differently based on the result? If the answer to that question is unclear, or if the treatment options for a positive result carry risks that outweigh the benefit in your situation, that's critical information. Second, what are the chances of a false positive, and what happens next if I get one? Understanding the downstream cascade of a test is just as important as understanding the test itself. And third, are the guidelines for this screening designed for someone my age and health status? Because, as we've discussed today, the answer is very often no. Medicine is advancing, and the conversation around individualized, age-appropriate care is growing louder. More and more research is confirming what experienced geriatricians have known for years, that for older adults, the goal of medicine should be quality of life, functional independence, and avoiding harm, not simply hitting every checkbox on a screening list that was designed for a different patient population entirely. You are your own best advocate. You have the right to ask questions, to push back, to request time to think, and to make decisions that are right for your life, your values, and your body. Don't let the fear of missing something push you into tests and treatments that the science says may hurt more than help. If this video gave you something to think about, if it made you feel more empowered walking into your next appointment, please hit that like button right now. It genuinely helps this channel reach more people who need to hear this information. And if you haven't subscribed yet, please do. I release new videos every week on evidence-based health topics that your doctor may not have time to explain. And before you go, I want you to watch my next video. It covers the 5 medications that are commonly prescribed to people over 65 that the medical community is now reconsidering. And one of them is something millions of people take every single night before bed. I'll see you there. Stay informed, stay empowered, and take good care of yourself.